Hello, this is Dr. Ashley Parks, and I'm here to provide a short overview of our Module 2, Week 2 content for our health behavior course. And so I'll be talking for just a few minutes about chapters 2 and 16. So we'll be talking a little bit about reflecting on case studies related to chapter 1 and our intro to health behavior, and then going into a little bit of a discussion about culture and program development and adaptation that we will revisit again later on in the semester. Thank you for joining me. So chapter 2 is basically a list of case examples of how we as health educators, public health professionals, health behavior professionals work to address health issues. And so normally I would get you all together in a live session on Zoom or in person and have you go through and discuss. And that's what I do during my in-person setting. What I want you to do to approximate this here, and I know we've got discussion questions in our online course and a forum. What I'd like you to do is consider which of these you would feel most comfortable being your day-to-day job. If you were working in a certain area, for example, there's health educators, public health professionals that work in injury prevention. They work in food and nutrition. They work in HIV, STD prevention. Which of these areas appeals to you? Which of these areas seems most foreign, most uncomfortable? I want you to think about that. And we'll be coming back to this a few times throughout the semester. So the first case is obesity. And your textbook provides a really open introduction to obesity. As you know, in the United States, we're looking at between 30 to 35% of adults being obese, not just overweight and obese, but designated as obese using the body mass index calculations. Now, I will tell you right now, as someone that runs marathons and lifts and still carries quite a bit of extra weight, I am not a huge fan of the BMI calculations. I don't think they're the best way to approximate health. But this is one measure that we work with in public health, one measure that we have. And of course, we want everyone to be as healthy as possible and to limit their visceral fat and other things that can cause health challenges. And of course, you can see Tennessee on this map is the second to third degree, the darkest red. And so we do have some challenges there. Now, one of the models that we use prominently when working with obesity is an ecological model perspective, specifically the social ecological model, but oftentimes we'll use models that integrate this setting-based approach. The idea that where you can receive food, do you live in a food desert? Do you have access to healthy food at school? Who you're with, do they encourage healthy food choices? And so we think about obesity and how it's influenced by individual factors. For example, I love French fries. That's an individual factor. That's a taste and food preference, which is very different than, let's say, a social factor. What do the people in my family eat? My mom's Cuban. She loves to make Cuban pork, which of course is not low fat. It is not low sodium, right? There's a little, and life is about balance. So we have to balance the foods that we eat. That interacts also with the cultural factors piece. And then of course we have to think about our access to food in the physical environment. And so this is just a quick example of how we see those models being applied. Now, your book talks for a moment about global trends. And it talks about this huge challenge that we've seen with obesity in China. Obesity tripled amongst young men between 1993 and 2009. So they went from a very, very low rate of obesity and overweight to now about 26% of Chinese adults being overweight, 8% being obese. And that may not seem like a very large increase to you, but it is huge when you think about a tripling in what was a very low rate. So that's something to keep in mind, and something that could largely be influenced by changes, by globalization and different social factors. This is a quick view looking at the prevalence of obesity and what we project by 2035. And you'll see the United States, we project greater than 55% of individuals living in the United States will be obese. And if you look, there's very little of that heightened rate, right? If you will notice, South Africa, South America, Australia are falling on our heels, Canada, Mexico, but not to the same extent. So that's obesity. Think about that. Would you feel comfortable working in food and nutrition? working in physical activity, working with data, looking at these health indicators. Now, next, this is an area that's near and dear to my heart, is HIV and AIDS. So the human immunodeficiency virus, and when we think about the autoimmune disease, AIDS, this is where I spent a lot of my career up until about 2017. By the end of 2016, we had about 36.7 million people living with HIV/AIDS. And this is internationally, right? This is across the globe. And addressing AIDS is a huge challenge for a number of reasons, right? We have to think about the social and the cultural context in different countries, the norms around sex and discussing sex, around safe sex, around the use of IV drugs and different types of risks, right? So we see this is another area where you may or may not feel passionate about working and engaging, but is definitely an area where health behavior comes into play. A complex relationship exists between HIV and AIDS because we have to think about HIV/AIDS behavior. How do we not stigmatize certain behaviors? How do we support certain communities? How do we act with inclusivity while still protecting certain individuals, realizing that by definition they are higher risk, but that doesn't mean that we can't design pathways and opportunities for them to have safe experiences. And so I know, having worked in West Hollywood, I used to work for the AIDS Healthcare Foundation. We worked with a lot of different groups, a lot of different genders, a lot of different sexual orientation, a lot of different backgrounds, and a lot of different perspectives on what it means to have safe sex, what it means to feel secure and provide consent, and what is considered a good time. And is it appropriate to have? We used to set up these condom stations all around West Hollywood and West LA so that they had access to these resources. So something to think about. We also have to be real about the reality that disease risk goes up in lower income populations that may not have access to either prophylactics or condoms, preventive measures. We also have to think about norms in different gender relationships and what it's like to speak up for yourself and advocate for self-sex. And we also have to think about economic patterns. We have to think about, well, is HIV/AIDS, fortunately, is no longer a death sentence, but access to treatment is also a challenge. And so we have to think about that and how we navigate that, and also navigate the stigma around morality and around sexuality in different countries and different locations. We also have to think about barriers. What can we do to help people increase their perceived self-efficacy so they believe that they can make change as part of the health belief model, in case you're wondering, to increase their perceived severity and susceptibility so they believe I can get HIV/AIDS, and if I do, this is a big deal. I need to prevent it. What do we do to change those things and deal with that tricky relationship between behavior, because HIV/AIDS is behavior driven, right? In many cases, in some cases not, right? And what do we do to protect individuals and all the various factors, all the way from the individual to the social norms, cultural norms, and then making sure the systems are set up to support individuals. All right. So this is a view of what the current, most recent data available, and this is 1990 through 2019. So we're looking at 2019 on this graphic. Our world data, I love it. It has all the little details, but this is the most recent I could pull earlier this year. This is the death rate from HIV and AIDS per 100,000 people. And you'll notice that the death rate is very low in the United States, right? We're looking at none to 1 to 2 people to 3 people. Whereas in Africa, we are seeing numbers in the hundreds, in the 500s per 100,000 people. And that is horrific, right? The fact that that's such a global health challenge, reaching those populations, providing resources. And so it's another deal. So far we've talked about obesity and HIV, two prominent and very, very high level data, two prominent health conditions that are inextricably linked in some way with behavior. Now we have youth violence as our last case. And youth violence is an area where I know in the spring course that I taught previously, I had a lot of students who were interested in exploring youth violence, because when we think about biological and social factors, where you're raised, how you're treated, what the norms are in your community, right? There's a lot of factors. When we think about violence in that ages 15 to 29 range, there's a lot of opportunity for improvement. So going back just for a second, so the homicide If we look at individuals ages 10 to 24 years, homicide is the third leading cause of death, right? These folks aren't as likely to have cardiovascular disease or cancers, right? Outside of childhood cancers, right? They're young, they're healthy, hopefully. Well, recent years, we've been seeing this jump in violence. So third largest cause of death if you're between 10 to 24, okay? Now, if we look at the data here, this is the number of youth arrests for violent crimes, and that has been on a decline over the last 15 years, which is wonderful to see that gradually decline. So we're seeing an effort to rehabilitate, support, develop community programming around youth violence, which again, wonderful effort. You can click on this U.S. Department of Justice report and read a little bit more. However, we also have to be really real and pragmatic in our program development, make sure we're addressing the existing risk factors. Are we addressing gang violence? Are we addressing norms in certain communities that support or cultivate a violent perspective? So when we think about this case, we often want to use that socio-ecological model again. The idea that youth violence can be very strongly correlated to social position. The idea that involvement in violence can be part of a group dynamic. It can also be part of an oppressed group dynamic. So if you feel like you have to do something for approval, for part of a group. Also, there's a lot of cognitive explanations when we think about reasoning. You have to believe that the payoff is greater than the risk, right? How we interpret social cues and hostility. And then from a developmental perspective, what does it feel like to feel unsafe or to feel like you have to prove yourself as an individual, as a young individual? And then lastly, I think it's really important for us to consider what types of biological, developmental, psychosocial factors lead to this, right? And so there's a whole discussion in your book about the idea that having limited options, having limited socioeconomic resources can really be a driver, but so can your community, who you surround yourself with. And then of course, the biological cues, the biological determinants around aggression and development and hormones as youth grow. So, so this was just a short little overview of 3 example cases. And so if you heard, we talked about obesity for a moment, HIV/AIDS, and youth violence. These are 3 areas where there's a tremendous amount of health behavior related work being done in communities. And so if you heard any of these and thought, wow, I would love to work in that space, or oh my goodness, no, youth violence is not my thing. Hopefully this kind of gives you an idea of some, I don't want to say obvious, but some very important, key, relevant, on the top of our mind issues in health behavior. And so if your group is struggling to think about a topic to work on your community-oriented intervention plan, these are areas where most communities are grappling with prevention and with health behavior related efforts. All right, so thank you so much. That was chapter 2, and again, not any new content, just 3 examples of applications of health behavior theory. We haven't talked about or learned about specific theories yet. We're going to get into that. So these are just 3 big areas where we may explore. Now I'm going to walk you through a few more slides. These are slides on chapter 16. So this is part 2 of our week 2 content. And this is specifically looking at culture, diversity, and health disparities. Now, if you explored my week 1 content, you'll notice I posted additional resources about health equity. And that is a thread that is tied and laced in every lecture and every discussion. And so these next 12 slides don't do any of that justice. We're just introducing this idea. So I just want to say that this is not a full picture. Now we're going to talk about some key theories in the first sections of this course. We're going to talk soon about social cognitive theory, about the trans-theoretical model, also referred to as stages of change. We're going to talk about the health belief model and the theory of planned behavior, also known as the theory of reason action previously. So we're going to talk about those theories, and all of those theories can be applied to develop custom health behavior, health education, public health intervention programs that are culturally inclusive, appropriate, geared to reach who you need to reach. And all of them can help us tackle health disparities in different ways, right? So all theories that I want you to start thinking about and looking at. I do want to say in our course, if you take a look, there is a section where I have all of the PowerPoints linked that discuss all of the various theories. And so if you look under, let me see, I believe it's week 5, but let me take a look. Is it week 6? I have uploaded some of the, it's starting in week 7, some of the individual theory-based information. So take a look at that. In addition to the chapter lectures, you'll see, for example, week 7, we have a focus lecture all about precede proceed. We have a focus lecture all about the health belief model. Take a look at those resources because those will help you learn those individual models a little bit more. They're discussed in our lectures, they're in our text. But sometimes it's nice just to have a PowerPoint that's all about health belief model. Okay, so for 5 minutes, what is health belief model? What are the key constructs? PowerPoint that's all about the trans theoretical model. So I've structured it that way too, of course. All right, so why health disparities matter? That's what we're here to talk about today. And I think it is beyond paramount that you start thinking about differences between groups in a way that gets you fired up, in a way that makes you want to bring about change and want to bring about equity and say, you know, this is not okay. This is not the world that I want to be in. And so health disparities refer to differences in health status, right? So if we have one group that's more likely to have a condition or to pass away from a condition, that's a health disparity. We also talk about healthcare disparities occurring when there's a lack of access to care for a certain group, when there's a healthcare issue, not a health issue. Healthcare disparities can cause greater health disparities. You'll also hear me use the term health inequity. And health inequity is really when we're dealing with a large, pervasive disparity that is so clear and prominent that one group is absolutely in a better or worse place when it relates to a health outcome compared to another group. All right. So one of the reasons that we study health disparities is because we realize, we acknowledge the fact that socioeconomic status, access to physical, financial resources, a safe place to live, a place to play, family that can be home with you when you're home as a child, right? Resources matter, and they are major determinants. We also want to be very upfront and direct about the fact that racial and ethnic discrimination is pervasive in our society. We've lived in a world with systemic racism, and now we're in a situation where we have the opportunity to turn the tide and to address that and to try to empower communities to address that. And so I think that's really important. I also think it's really important that we realize there's a lack of cultural competency and understanding of different populations and how to reach them. And so it's part of our job as public health professionals to become educated to do that work. So this is one of my favorite graphics ever. This is from the Kaiser Family Foundation, and you've seen it in some of my other presentations. I'll lace it in there when we're talking about different factors. This is looking at how health disparities are driven by social and economic inequities. And instead of having racism be a part of the community piece or a part of what's happening in our healthcare system, it is this band that goes across all areas. We have discrimination and challenges there when it comes to food, education, community safety, economic stability, job opportunity, our healthcare system, all of it. And all of these factors drive our ultimate health status. And so we have to be real about the fact that walkability, linguistically competent providers, debt, expenses, food security, all of these come together to dictate our health in one way or another. And of course, we have individual behaviors and individual agency, if you will, the ability to choose, but we still have to be real about these drivers, these determinants. So lots of different ways we can address health disparities. You've already seen what's on this slide and the next slide, but I want to recap on it again. We've got individual approaches, things we can do for individuals. We can educate them, we can work with them, we can increase their confidence, their perceived self-efficacy to do something. And so you'll notice under individual approaches, we've got the health belief model, right? We've got the theory of planned behavior and social cognitive theory are listed there. And that's all I give you. Well, because we're going to talk about them ad nauseum soon, but those are 3 individual theories. Under social and community theories, you'll see there's a little note about the idea of community mobilization and this concept of community efficacy, the idea of the community feeling empowered to do that work. We also have social network theory and the socioeconomic models that are part of that, socio-ecological model. Then we have organizational level theories, work that we do at an organizational level when we think about projects, when we think about CDC and how they develop, planning processes for communities, this org theory component. And then these multi-level approaches like the Thrive model that look at addressing across individual, social, family, community, across all the levels of the socio-ecological model. So the next slide, there's a link here about the project, but the next slide is a slide for a project that I did almost 15 years ago. I think this is 2011. This is the Turning Data into Action project, which is a project that I did with communities in Long Beach and Boyle Heights, looking at efforts to improve air quality and reduce exposures and to positively impact low infant birth weight, cardiovascular disease, and asthma risk in these communities. And so we used a CDC framework in order to work across multiple levels to tackle that. Now, if you go to the next slide, you'll see this is a prime example of a health disparity. Black and Hispanic Medicare beneficiaries. So these are individuals over the age 65 and or disabled and or end-stage renal disease or Lou Gehrig's disease. These are sick and or aged individuals. They're looking at it with their race ethnicity distribution. We see that white individuals are less likely to have hypertension, diabetes, stroke, or depression compared to Hispanic individuals. And this is true for in comparison to Black individuals in one area, except for depression. Depression is a little bit lower for Black communities. Now, we can postulate as to why that is. I've attended some different seminars and health education events looking at how individuals from certain communities of color process, cope, manage stress in different ways, and how it's reported and dealt with, right? So you may not be going to see a clinician, therefore you're not getting a diagnosis. So this is interesting to see. When we look at something like stroke or hypertension that needs to be dealt with, you'll notice these differences. Now, I do want to say we don't have cardiovascular disease as a whole up here, and I wish we did because we would see some really stark numbers, but hypertension is a good proxy for that. Look at how much higher, almost 80% of Black individuals who are participating in the Medicare program, so again, 65, are experiencing high blood pressure. That should be a considerable concern. Now, we should also be concerned about the fact that this is obviously pervasive because we also have white and Hispanic rates that are elevated or that are high, not comparatively, but higher than I think is acceptable to say 2/3 of the population has high blood pressure for elders. But this is an example. Going back to that low infant birth weight, which was one of the topics from the poster I just showed you, this is looking at infant mortality by race ethnicity, and you'll notice the Black number is so much higher per 1,000 live births. And I apologize, the scale got cropped off of this, but you can see the difference. It's pervasive. There's a lot of disparities. This is a closer look at that data. When we look at low birth weight versus preterm versus infant mortality, those green, not the different shades of blue, but the green is specifically Black populations, and you'll notice the much higher rate. To say that in 2020, 10.8 per 1,000 live births. What we're not saying is 10 per 1,000, that's a percent. Percent of babies born to Black households in 2018 died within a year. A percent. 1 out of every 100 Black mothers are living with that heart rate. Like when you think about these numbers as people, I just want to highlight that. So these are some really pervasive disparities. And this is a little quote from Drew Altman, Kaiser Family Foundation president and CEO at the time, who talked a little bit about this survey. Okay, so this is just a high-level overview, so you can see some disparities that persist and a little bit about how we are going to talk about designing programs across each of these domains with many types of theories. If you feel like right now, Parks, we haven't talked about anything yet. What am I designing? What is the theory? Tell me. We're going to get there. I just need you to acknowledge and see how important this work is. And then we will go through theory by theory each week and talk about application and look at the models and the arrows and make sure that we understand the different constructs and the important things that we can do as professionals to work with these communities. All right. Well, thank you so much for taking the time to listen. I hope that this was helpful. And I look forward to sharing with you again next week. Thanks, everybody.